Hello everybody, it's your boy Saiken MD here with some internal medicine board review.
Hi everybody, my name is JFMD, but I go by JF. I'm your medicinal plant dragon VTuber ? But I'm also an internal medicine doctor, just like Saiken MD.
Yeah, let's get started with undisclosed, nondescript board review questions. Sponsored by one of the PGY3 residents that I'm working with. I hope he does well on boards. Certainly better than us. A 20-year-old woman is brought to the emergency department from a college dorm. She attended a party earlier that night and was brought back to her room by her roommate. The roommate told paramedics that she called for an ambulance because the patient was agitated, combative, and confused, and then appeared to have a seizure. The patient was obtunded by the time the paramedics arrived. She has a history of psychosis and takes risperidone and diphenhydramine nightly. When I'm talking through the questions, basically the biggest thing in a board question is the question stem. There are only so many different ways that the exam can ask about different conditions that it's really important to see what the actual question stem is saying. Every piece of information that they give you is important for a reason, and every negative piece of information that they put in there is also important too, because they either make things extremely obvious for uncommon things, extremely uncommon for common things, or common for common things. There's usually not going to be like a super rare presentation of a super rare thing. Emergency department from a college dorm, you're thinking of a 20-year-old. They were at a party earlier that night and there was like an acute mental status change, right? She became agitative, combative, confused, and appeared to have a seizure. So I'm worried about like acute intoxication, what kind of drugs, what kind of drugs could do these things, right? So agitation, combative, confused, you're thinking stimulants, you're thinking things like, in terms of drugs, you're thinking of things like Molly, PCP, maybe even acid, right? And what am I finding important here is that the patient also has a history of psychosis and takes risperidone and diphenhydramine nightly. So the patient already is on an antipsychotic and taking a antihistamine every day. And on top of that, they are taking substances at this party that is leaving them agitative, combative, and confused. So I've already kind of got a differential going on there, like thinking about different things that could be happening at this college party. So now I'm going to approach the physical exam and the vital signs with, this in mind. Temperature is 103 degrees Fahrenheit. Blood pressure is 179 over 108. Pulse is 135. Respirations are 24. Physical exam shows a young diaphoretic woman who is warm to the touch. Pupils are dilated. There's no nystagmus. Occasional tremors are noted, and she is hyperreflexic. When you see these things, what's screaming out to me is, yes, her blood pressure is very high, her pulse is very high, her respirations are very high, but also the fact that she's extremely febrile. She's got a 103 fever, right? And she's sweating, and her pupils are dilated. So, somebody in the chat already got it. This kind of is, pointing more towards something like serotonin syndrome, or what's the other one called? NEMS, like neuromalignant. What's it? NMS? What does it stand for?
Yeah, NMS, exactly. Yeah, neuroleptic malignant syndrome.
Neuroleptic malignant, yeah. So basically you're thinking of like your body overloading, overheating, the on switch is constantly on. The hyperreflexia there being that like you try to elicit their knee-jerk reflex and their knee basically just shoots out immediately. So is it like a stimulant medication but not MDMA, because wouldn't that cause nystagmus, right? So now you're thinking what drugs can cause things like serotonin syndrome or NMS, and also what drugs would interact with the patient's normal medications that could cause this presentation as well. So here I'm going through, the labs. So they're hyponatremic, bicarb is 28, BUN is 38, creatinine is 0.8. They've got some transaminitis going on. Their INR, their liver and their clotting factors aren't doing too well, and their CK is high, probably because, their limbs are essentially going super ballistic, and also probably like cramping. We got to the answer choices here. So which of the following is most likely ingestion causing the patient's findings? So we've got 3,4-methylene dioxymethamphetamine, we've got diphenhydramine, we've got phencyclidine, we've got psilocybin, and we got risperidone. So I thought it was MDMA because it's causing a serotonin syndrome for the patient, which for me, I was thinking more on the hyperreflexia angle and the new fever, and I ended up getting that one right.
There's a big difference between the questions like these and doctoral, right? Where you can tell like this is like a multi-layer question. Like you can tell, okay, maybe something is up with an ingestion, some kind of recreational drug or something from the start. But the question itself is even trying to push that further and say, well, it doesn't exactly fit any toxidrome for a particular drug, right? I think someone in chat was talking about how there's no nice agonist, so it doesn't sound like it's Molly, but that's where the question tries to get you. It's not because of a drug itself, right? It's like what happens from ingesting the drug, that serotonin syndrome afterwards, which Molly's not the only thing that can cause serotonin syndrome, right? Other things can too, but it's kind of recognizing that additional step after. That's the level that these questions are at, because it's not just like, boom, I've got one drug, that's the flashcard on one side, the other side is, oh, this is what it is, right? You got to recognize that the drug is responsible for the syndrome, and then the syndrome then does this. It's like multiple steps, and that's how these questions are, most of these questions are of these level, because when you get to this point, you have to like take into account the entire situation. It's not just one thing in isolation. That's honestly a lot closer to what medicine is in practice, because one person's just not one like textbook question. They've got a lot of different things, and can be the thing they had for dinner 3 nights ago or something. You have to take everything into account when you do a good history and a good exam, as well as kind of what testing you want. All of that has to be factored in.
Yeah, if you watch medical TV shows like House or whatever, like they always do the thing called the differential, right? So the differential diagnosis is the process where the doctors are going through the very many possibilities that could be, what the patient is presenting with, and trying to narrow it down, but also ruling out why it's not the other things. At this point in your training, right, when you've gone through med school, you've gone through residency, like, yeah, the correct answer is probably screaming at you. And, if you do medicine like that and treat patients based on probablys, like, yeah, you'll probably get like 85% of the correct diagnoses on the first try. But, when you're actually working, right, when lives are at stake, when the medico-legal implications of your license are at stake, right? It's not just enough to make sure that it is the thing that you think it is. You need to logically make sure that you're ruling out why it's not the other things that could also present like it.
A 35-year-old man comes to the office due to bloating, excessive flatus, which is having too much gas, and loose stools since an episode of food poisoning several months ago. The patient had been on a cruise ship when he developed nausea, vomiting, and diarrhea. Uh-oh. Several other patrons developed similar symptoms that resolved with supportive care only, which is like fluids and rest, but no real medicine required. The patient's current symptoms began 1 to 2 weeks after returning home and usually occur in the morning shortly after breakfast, so with food. His usual breakfast consists of coffee with whole milk and cereal or oatmeal. It's a pretty good breakfast. Yeah. Soon after eating, he develops bloating, followed by crampy abdominal pain and loose stools. The symptoms occasionally recur after dinner. Medical history is insignificant. The patient drinks 1 or 2 beers on weekends and does not use tobacco or illicit drugs. He reports no other recent travel outside the country or unusual food exposures. Saiken's doing a great job of doing what we would do in an actual exam, highlighting the very relevant points here. So looking at this, it definitely sounds like there's something going on. System-wise, it's the gastrointestinal system, of course. There's gas, there's stool, there's bloating. What else could possibly be? But specifically what's going on with the gastrointestinal system, we think about the age, we think about the exposures, and we think about the symptoms that someone's having in the time frame, right? This is a relatively young gentleman, so we think of some of the older things that might be more relevant there. Probably won't be as applicable to this guy. On the other side, right, there are some conditions that are more common in younger people. For example, inflammatory bowel disease or other forms of autoimmune and intestinal diseases that are more common in younger people than in older people, just because what we think of the causes is like a stronger immune system can lead to an overactivity, and that's what actually causes autoimmunity, right? So a 35-year-old man, their immune system probably is very robust versus like an 80-year-old gentleman. In addition, these symptoms have been going on for about a couple of weeks and on and off, and they seem to be associated with some particular exposures, in this case, right after breakfast. And they conveniently tell us what their breakfast is. Coffee with whole milk, cereal or oatmeal. It sounds like it's related to food and associated with loose stools and bloating. No medical history, right? So there's nothing to suggest that this was something that occurred in the past either, as far as we could tell. And in terms of the social history, other recreational substances, alcohol, smoking, really just what sounds like social alcohol use and nothing else. So nothing else there. With that in mind, then we think about the exam. What do we expect to see doing the exam, focusing specifically on the abdomen, right? Taking a listen, doing palpation or pushing down to see if that elicits pain. And it looks like vital signs are normal. So for most other things, there's something more serious going on that we can tell. The abdomen is soft and non-tender. So as far as we could tell today in the office, right? Because not everything happens when you go to the doctor's office. Sometimes you're like, oh, I should probably make an appointment to see the doctor. and then you feel better and you're like, yeah, sorry, doc, I guess it's gone. You scared it away. It happens all the time when I see people in clinic. Bowel sounds are present with loud borborygmi. That's a great word for the gurgling you hear when you hear your stomach rumble. That's what doctors have to call it because we have to be very fancy.
I just say bowel sounds.
I also just say bowel sounds. There's no need to be fancy. No hepatomegaly or splenomegaly, right? That's just fancy words to describe that the liver and the spleen are also not swollen at all, which can be signs of either failure, infection, or something going on there. So things seem to be pretty normal on our exam, besides the loud sounds. I don't know if I would do testing. And the reason why is testing costs money for most people, at least in the US, right? It takes time. And there's also the consideration of false positives. Like what happens if the test comes back and it says, oh, something is wrong? Does that actually line up with what you suspect as a doctor? Or could it be a red herring, right? That's important because if I then call the patient and I'm like, this test shows that you might have cancer in this 35-year-old, right? Is that likely or not? What we think about here, for example, is the most likely differential on my differential diagnosis, the most likely thing that I think it might be is probably something that's pretty mild, right? And if I want to commit this person to a whole workup, and you can see here the question here is, what should we do? What should we do to test, or should we even do any testing? Should we skip the testing and just try something? And you may have been in a situation with your doctor in clinic where you might be thinking, well, man, my doctor didn't order any tests. What are they thinking? Do they just know what it is, or are they not going to bother with any testing? Why is that? And sometimes the testing isn't worth it. It's not worth what we're looking for, and it might not even be helpful to tell us what we're looking for. You know, some of these answers can be right in a textbook setting, right? They can get you what you're looking for, but is it the best option here for the person who's sitting right in front of you in the office? Or is it going to be unnecessary? That's kind of another facet of these questions where it's not just what's right on the flashcard, it's what should we do for this person that's the best for them. It's complicated, right? Best is a very tough term. So we order some basic tests, my bread and butter basic tests, blood count, chemistry is like a metabolic panel, thyroid testing, and inflammatory markers and infectious testing, all are absolutely normal. Even more reassurance that this is not a big, serious issue. So I went on a long-winded talk about how we do differential diagnoses and how we actually test things in the clinic, because it's something that doctors don't do a good job of explaining in the clinic. I'm also not entirely free from this, because if I have 15 minutes to talk to you, am I going to spend the entire 15 minutes I just did talking to you about why this is not the best choice? Or am I just going to say, no, we're good, and call it at that? There's always the time constraints, right? But even just by talking about this, kind of a sense of what it was. And the clue here is that it comes after meals, and the meals he has usually have milk in them, right? And what can happen, especially after a recent infection, which he probably got at the cruise ship because other people around him also got that, usually as a clue for infection, is that people might be more sensitive to milk products, what we call lactose intolerance. And so then what should we do here, right? Should we do a stool sample or a fecal fat collection for 72 hours? I would never subject anyone to that. That's like a 3-day collector of poop from the toilet. Or should we simply just say, D, let's give a try holding off on having anything that's dairy related and see how you feel? I feel like that's probably the least maintenance, and it could give you the answer right away.
Yeah, I agree. I have zero complaints with recommending a trial of dietary lactose avoidance. I'm pretty sure we're correct. I'm just gonna hit it here. That's pretty much what's happening here.
There you go.
So he had a recent inflammatory bowel illness, and that probably messed up his the terminal villi or whatever, and that messed up his intestines. So I think somebody was saying that like, oh, lactose intolerance, but it wouldn't be this long, since the cruise. But apparently, it can take several months for it to come back. So his cruise was several months ago, and he's still having problems with digesting lactose, and he's still having coffee and whole milk and cereal and oatmeal and all those things. So yeah, easiest way is just, see if you can tolerate a lactose-free diet, and then over the next couple of months, like, start slowly reintroducing it. 68-year-old woman is admitted to the hospital due to shortness of breath and lower extremity swelling for the past 6 weeks. Her medical history includes hypertension, which is high blood pressure, hypothyroidism, which is low thyroid function, type 2 diabetes, hyperlipidemia, which is high cholesterol, obstructive sleep apnea, and stage 2 chronic kidney disease. The patient had a transient ischemic attack, so kind of like a mini stroke, with a right carotid endarterectomy 8 years ago. So the vascular surgeon went in and basically cleaned out her carotid artery of all of those cholesterol plaques. Home medications include aspirin, levothyroxine, hydrochlorothiazide, which is a diuretic, lisinopril, which is an ACE inhibitor, atorvastatin, which is a cholesterol medicine, and glipizide, which is a diabetic medication. She has never used tobacco. All right, so we've got shortness of breath and lower extremity swelling. So these sorts of things, you're worried about a fluid overloaded state. Definitely something that happens quite often in heart disease, right? Your heart is a pump, and if things aren't pumping forward, things are going to start backing up. And what's right behind the heart? The lungs, right? Behind the lungs is the right side of the heart, and behind the right side of the heart is the rest of your body, right? So if your fluids aren't going forward correctly, these things are going to start backing up, they're going to start third spacing, they're going to start depositing in the rest of your interstitial spaces. I'm thinking of a fluid overloaded state, right? I'm seeing some people saying heart failure, HFpEF, so heart failure with preserved ejection fraction. And she is on a bunch of medications already. Temperature is 99 degrees Fahrenheit, blood pressure is 122/80, pulse is 84, and respirations are 22 a minute. So, she's afebrile, her blood pressure is pretty good, her pulse is fine, but respirations, she is breathing pretty quickly, right? Pulse oximetry is 92% on 3 liters oxygen via nasal cannula, which means that probably at baseline without it, her pulse ox is probably like 80, 87, 80, 86, which is not great. So she's needing 3 liters of oxygen being delivered through that nasal cannula in order to keep her sats up. JVP is elevated at 12. Lung examination reveals decreased breath sounds at the bases, with bibasilar rales up to the lower 1/3 of the chest. So basically she's got like crackles in the lungs, and you're going to be associating that with, the fluid overloaded state. Cardiac examination reveals a normal S1 and S2 and an audible S4 over the cardiac apex. And there's a 1/6 holosystolic murmur heard over the cardiac apex. She's got 3+ lower extremity edema up to her knees. So when you push down on her legs, she's doing something called pitting, which is, you leave like your thumb imprint in your legs, and because there's so much fluid there, it actually ends up squishing down and leaving an imprint, and it's taking 3 seconds or more for that to basically puff back up. The remainder of the physical exam is within normal limits. So yeah, we're in fluid overloaded, definitely heading towards heart right now. But we'll see what all these other labs are saying. Sodium looks fine, potassium looks fine, chloride's fine, bicarb's fine, BUN's fine. Creatinine looks like she does have a little bit of an acute kidney injury. Calcium's fine, glucose looks fine. Biggest thing is the pro-BNP, which is quite high. So BNP stands for brain natriuretic peptide. For the context of heart failure, BNP is a chemical that's released. What is it? The stretching of the atria, right?
Yes.
So when you're in a fluid overloaded state and your heart is basically getting stretched because it's trying to accommodate for all that extra volume that it's got to push through, When your atria, which is the top chambers of the heart, end up stretching, they release something called BNP, and we kind of use that to correlate, somebody's heart failure status. Initial chest x-ray reveals cardiomegaly and bilateral pulmonary vascular congestion with small bilateral pleural effusions. So everybody's kind of been saying the same thing, right? Like, we are thinking about a heart failure picture, right? They've got a big, sort of weak heart. It's cardiomegaly, which means that the heart size is big now because it's gotten all floppy and the pump isn't pumping forward correctly. We have bilateral pulmonary vascular congestion, meaning that these vessels are now getting engorged because the fluid isn't pumping forward, and small bilateral pleural effusions because now we're third spacing into the pleura of the lungs, and that's probably is what's causing, or that's just all of these is a consequence of the heart not pumping forward and the patient is having trouble breathing. A transthoracic echocardiogram shows normal left ventricular size and a left ventricular ejection fraction of 65%. So an echocardiogram is an ultrasound of the heart. And this is something that you do in order to take a look at the structural abnormalities of the heart. You want to make sure that you get a good view of the valves, not too narrow or not too leaky. And then a big thing, at least for medicine people, cardiologists probably care more about other things, but for us, like, an ejection fraction is probably the simplest way to describe heart failure. So like a normal heart, you want to be pumping all of the blood that comes into the heart. You want to be pumping all of that out, right? So in this person, they're only pumping out about 65% of the blood that goes in and the blood that goes out. So they are backing up, and that's leading to a lot of their symptoms. Moderate concentric left ventricular hypertrophy is present. So they are having to do extra work on the left ventricle, which is the part that pumps through the aorta, which is the largest blood vessel in the body. And basically it's saying it's going to have to be overcoming a lot more just because the heart is so floppy. The left atrium is moderately dilated, and we talked about this when we were talking about the BNP. A central jet of mild mitral regurgitation is present. So with mitral regurg, we were talking about the leakiness of the mitral valve, and that's basically saying that even when the atria is trying to empty into the ventricle, there's still a bit that's jetting back and remaining inside of the atria instead. Pulmonary artery systolic pressure is estimated at 45 millimeters of mercury. So there is some difficulty with getting blood into the pulmonary artery, which is the right side of the heart, where it's then going to go to the lungs, get oxygenated, and then go back to the left side of the heart so that it can get pumped out to the rest of the body. So a pulmonary artery pressure of 45 is quite elevated. So the right side is also having difficulty here, making sure everything goes through. So, all of that is to say, which of the following is the most appropriate next step in the management of this patient? We're thinking heart failure, right? What do we want to take a look at first? Optimal volume control, pulmonary function testing, right heart catheterization, treatment with angiotensin II receptive blockers, and treatment with beta blockers. So I think we're all saying that this is probably heart failure. And now it's a question of what kind of heart failure. We have a left ventricular ejection fraction of 65%. So, I mean, it's going to be heart failure with preserved ejection fraction. We also have proof that the right side is involved as well, because he does have an elevated right ventricular systolic pressure, or pulmonary artery systolic pressure, basically interchangeable. So, I mean, in terms of diagnostics, the most appropriate next step, I mean, I'm already putting a name on this diagnosis, and we already have some of the numbers here to actually, make this diagnosis. So the next step that I want to manage this patient with is probably volume control. They are coming, to the hospital because they're short of breath and they have a lot of swelling on their body, right? I don't think I need to subject them to any more tests, in order to figure out what's going on here. The most important thing right now is that I try to get as much fluid off of their system as much as I can so that they can get off of this oxygen in the hospital and, hopefully, get started on a better diuretic regimen and, try to follow up with the heart doctor outside of the hospital. What do you think?
Yeah, this is a very technical question. There's like a lot of
going on here.
And words. Yeah, there's a lot, and even the answers, I feel like there's a lot of detail here. So I think a lot of people in chat I was seeing had the sense that this is heart failure, right? It has that kind of picture, and for those who are unfamiliar with medicine who may not been through med school yet or pre-med, what we call heart failure is really just telling the heart, you're not doing as good as you should, right? I actually had a patient who, when I said those words, they were like, I'm dying, my heart is failing? No way. No one told me that. And it doesn't mean that it's a imminently life-threatening problem, but it just means that your heart is not doing as good as it should, right? And it can get worse, and that's a problem. In this situation, this patient is coming to see Dr. Saiken in the hospital, right? In the hospital, not just out of the hospital in the clinic, because they're feeling sick. They're feeling out of breath. Things are not going good. They got swollen legs. Sometimes they can get so heavy you can barely walk, or their shoes don't fit, their socks don't fit. If the heart's not doing so good, it's a pump. It's supposed to be pumping blood forward. You can think of it like the water pump in your house, right? If you're not pumping blood forward, water forward in your house, what happens? Your basement floods, or wherever your water pump is, it floods over because all the water can't get out. So then what's the body's equivalent of that? It's your legs and your lungs. So this patient's now coming to Dr. Saiken to say, how do I get this to feel better? Or should we do something to try to diagnose it, right? Which is what Saiken was getting at. And that's one of the tricks about questions like these is, do we need to do more to figure out what's happening? Or do we know what's going on and we can skip all the other testing? That's where some of these answers are confusing. You can see right there. Most of these answers are actually fairly reasonable. B and E, I would say, are not reasonable for like very technical reasons. And that's why no one picked B and only like 1% of people picked E. But you can see C, 13% of people were like, maybe we should do this test. And it's a very like technical specific test that you can do to get more info to call it heart failure. But like Saiken was saying, if you already know it's heart failure, why make someone do this test? They're already feeling miserable. What we can do instead is to pull that water off, what we call volume control. Usually you have to get them pee all the water out, and that's what will make them feel better.
Yeah. So a lot of people in the YouTube chat, actually, especially, were, kind of debating what the correct answer is for here. So for me as a hospital medicine doctor, like heart failure exacerbations, like are my bread and butter, right? Like if I'm taking care of like 22 patients on my list, like I guarantee like at any given time, like at least 4 of them are going to be heart failure, right? It is a very common problem in America, a very common chronic disease that can get out of hand very quickly, especially in an older population.